Good afternoon and welcome to the Fund for Women and Girls annual luncheon. My name is Isabel Zisk and I have the privilege of co-chairing the fund with Jennifer Morak. Jen will be here later in today's program to lead the Q&A and to ask you for your financial support. Most of you are well acquainted with the Fund for Women and Girls work and mission, but for those of you who aren't, we are a field of interest fund within the Princeton Area Community Foundation's family of funds. The fund is comprised of individual members working together and pooling our contributions to improve the lives of economically vulnerable women and children in our community. We strongly believe that we can do more together than we can on our own. And last year we gave almost $250,000 in grants to area nonprofits to change the lives of women and children. Today we're focusing on health equity, the pandemic, and the next normal. It is my honor to introduce our two panelists, Dr. Richard Besser, President and CEO of the Robert Wood Johnson Foundation and former Acting Director for the Centers for Disease Control and Prevention, and Dr. Kemi Ali, CEO of the Henry J. Austin Health Center in Trenton. In order to provide the most time to our speakers today, I will forego reading their impressive bios. But if you'd like to read more about their work, the links will be in the chat. After the discussion, we will have time for questions. So please feel free to put any questions you may have in the chat, and we'll try to answer as many of them as we have time for. And with that, I will turn it over to Dr. Ali.
Hello, everyone. Thank you for this opportunity. I'm very happy to be here with you today. Hi, Richard.
Hi, Kemi. Good to see you.
Likewise, likewise. All right, so we're here today talking about what's happening around COVID in our community and also on the national level, getting that perspective as well. You know, what's been really interesting, and there's been a lot of discussion around vaccine hesitancy. Particularly in communities of color, so African American, the Latino communities, you know, and so it's real interesting to sort of think about what can we do? What can be done to raise this level of trust, whether that is locally, whether that's on the national level? What are your thoughts around that in terms of what's a sort of national perspective on reducing vaccine hesitancy in some of our vulnerable communities?
Yeah, you know, it's interesting. I've learned a lot through some of the conversations I've had around vaccine hesitancy, and even that term, you know, especially as it applies to communities of color. You know, when you look at hesitancy right now, I mean, some of the biggest areas of concern and gaps are among people who self-identify as politically conservative, and among young people, and we're seeing increasing demand among people of color as vaccines are rolling out and people know family and friends who've been vaccinated. But that whole concept, especially early on around vaccine hesitancy, was, you know, what will it take to make more Black people comfortable with getting vaccines? You know, what can we tell them?
Yeah.
And I was in a conversation and it was flipped around to say, what do we need to do to change our institutions so that they're more worthy of trust?
Exactly.
And you know, acknowledging the long history of disrespect, frank abuse and medical experimentation that the African American community in America has experienced. And I think shifting that frame from this is something where you have to fix the individual to one where you have to look at the system and the structure is so relevant to the whole conversation around health and around health equity. I mean, what have you seen has been the reasons for increasing uptake among the community you serve?
I think it's exactly what you just said, you know, and so trust is a really interesting word, right? So trust is something that is built over time. It is a set of our experiences. And so again, when someone says, well, how do you raise the level of trust within a community? It's really something, as you said, it's over decades. It's not something that you can go in one day and have a health fair and now everybody trusts you. So I think we've circled back to what you said, in that the health industry as a whole really needs to rethink how we the systems and the practices we have in place that have disenfranchised individuals for so long. And now we're seeing the consequences of that. But I think what we've learned from that in the short term is that there are some trusted entities within these communities. And how do we tap into that? How do we leverage that now? So is that, quite honestly, an institution like a Henry J. Austin, a federally qualified health center that's been embedded within the community? Is it our faith-based communities? Is it our local champions? Is it sometimes lawmakers or legislators that are really active in our communities? So I think what a lot of communities are now learning is that because so many of those communities that you mentioned don't have that trusted relationship with the healthcare institutions, we really got to come outside of that for this moment if we want to be able to engage those communities. And where have they built trust? Where do they have those relationships? And there was this whole other interesting conversation, as you mentioned, that really, if you look at the large numbers of individuals that are not getting vaccines, it is the younger crowd, that 20, 30 age that think they're invincible. And then those that identify as really conservative. And, there have been some interesting thoughts around that too. How do you get to those populations? And I know there's one organization that's doing something very interesting called A Shot for a Shot. They're going down to the Jersey Shore and you get a shot, and they're setting up at breweries and things like that as young individuals get ready to start their summer season. But I think it's more things like that we've got to think outside the box. And I really think we are going to have to take the vaccine to where people go, where are they already working, living, playing, and take it to them to get to those individuals that are sort of on the fence.
Yeah, there was, I think early on, a really false narrative that the primary reason you were seeing lower rates of vaccination among Black Americans, Latino Americans, was this issue of hesitancy, rather than the fact that the barriers to vaccination weren't being addressed.
I agree.
There was such a focus on the number of people being vaccinated and not whose arms are getting the vaccine. And recognizing this pandemic has hit every community, but it's hit Black Americans, Latino Americans, Native Americans so much harder. There was not enough effort early on to reach people where they were, reduce barriers, recognize that if someone is working a job and doesn't have sick leave or time off, and the only time you're able to get a vaccine is during the work hours, they're not going to get vaccinated. That's not a fair choice. And it started with the last administration, but it continued with this one, where the focus was, well, we have to get 3 million doses a day.
That's right.
And it's like, well, yeah, the number of people does matter, but are we providing vaccines to the people who've been hit the hardest and making it as easy as possible? And I'm on the New Jersey Restart and Recovery Commission, and I saw some data yesterday that was encouraging to me, because it was coming at this from a lot of the systems that you were just describing. Yeah. So vaccine clinics set up in churches, in community centers, in places where there is a high level of trust. And it was bringing vaccines to people's doctors' offices where there's a level of trust, and not requiring that people get in a car like I did and drive an hour to a mega site. It's a different frame. And what you see is, when you make it easy, a lot of the people who may have been on the fence, or a lot of people who really wanted vaccine but couldn't get there, are getting vaccinated.
That's exactly right. It's so interesting about inequities and disparities when we talk about them. In that, I always remember that the the diagram, right, of, you know, 3 children trying to look over a fence, and one is short, one is medium, one is tall. If you give them all the same stool, the person who's short still cannot see over the fence. And then if the fence is lopsided to also, then they really can't see over the fence. And so when you look about, when you're thinking about reducing disparities and inequities, you've got to give the shorter child with the higher fence a bigger stool. So that's really how you then make a level playing field, to keep going with that analogy.
Yeah.
And so that means, to your point, we have to be intentional about creating systems and designing systems to reduce those inequities. And we didn't really do that with the rollout. And I think that's a real lesson learned. We sort of said, we've got all these shots to give, as you said, let's open up really big and give it to the mega sites. And that's where most of the vaccines went. And a smaller proportions went to the communities. And then as we learned, but we should have kind of knew that already, but as, you know, as experiences grew, we saw the percent less and less of African Americans and Latinos, but we knew they had inequities built into their systems. And so we had to be very intentional about designing from the beginning, how do we overcome that? And I think it was one of the lessons learned, one of the definite things I take away from this experience, about being very intentional from the beginning, because we know those disparities exist. You know, speaking about that, you know, the other thing that we'll have to, and lessons learned, really think about as we go forward is those communities that have been hit harder. So we know that the African American community had a mortality rate 2.5 times their Caucasian counterparts. We know the Latino population had a mortality rate 3 times their Caucasian counterparts. So those communities really have been hit hard. And there are some long-term implications with having COVID in those communities, you know, particularly when you look at the Latino community, just the number of younger Latino men that have died, you know, just whole families wiped out. And what that means for a whole community, right? Those are the working individuals, they are the stabilizing foundation. I think we're really going to have to think about what does that mean, and how do we then build systems to impact that, to reduce those disparities that are going to be almost inevitable as a result of the COVID and how it's hit those communities particularly hard. Yeah, what are your thoughts around that?
Well, I think that it's going to be a long time before we fully understand even the extent of the impact. Yeah. One of the things that I hear all the time is that, wow, you know, children have been spared by this pandemic. The attack rates, you know, the rate of death is so much lower, and hospitalization is so much lower. You know, and yes, that's true, and that's a good thing, but it really underplays the impact. So when you talk about losing so many Latino men, they are parts of families, and so that's children who are losing fathers. More than 40,000 children in America have lost a parent during this. There have been thousands of children who've developed an unusual inflammatory syndrome, hundreds of children who have died, countless children who have missed the opportunity to be learning in person and in interacting. And you know, you and I are both pediatricians. We know how critical these kinds of impacts are. I think we're going to be facing going forward a couple things. One is dealing with the impact of all of that in terms of children's development. The other is, you know, as vaccines become available for children, we're going to be faced, I think, with the situation of what information do people need to make to make an informed decision about whether to get these vaccines for their children. That's right. And how you consider that. For me, I don't think there's a vaccine I've met that I haven't liked.
That's right.
I've just seen the power of vaccination, but I know that that's not that's not the general feeling by
Right.
a lot of people. It's like people get vaccinated because either they have to,
Right.
or they've had an experience in their life. But we're dealing with generations that haven't seen most of the
That's right.
diseases that they're vaccinated against.
That's right.
COVID will be an exception to that.
Yeah.
But I think that this fall, what's your sense? As in the next week, we're likely to have a vaccine
That's right.
that's approved or authorized for
children.
teenagers. Do you think that your clinic patients will want to get that?
Yeah, as you said, it's so interesting. And I think a lot of our families, particularly in communities like ours, they get the vaccine because they're required to, because children need to go to school and most parents need to go to work. So they can't stay home and homeschool, quite honestly.
Right.
So their children have to go to school. It's mandated. So they get the vaccine. So it will be really interesting to see what happens in the fall if it's not mandated by the school systems. Some universities they've taken that road already to say, if you're going to be in the classroom, then in a university like, I believe, Rutgers, you have to be vaccinated. It will be interesting to see what the conversations are among families if it's not required, for all the reasons we're discussing about that distrust of the systems. But I like you, as you said, we're pediatricians. This is the bread and butter of what we do. I have to understand, I have to have faith in the system of vaccines. I've seen it and again, save lives. As you said, I've been in the ER and seen the children come in with meningitis, seen the children come in with varicella spread throughout their neurological system. I've seen that devastation. So for us, it's really easy to put that together with the data, with the science, and say it's really sound. We have institutions in our society that we have to trust, otherwise we can't function. Yeah. We will not be able to function. And the CDC and the FDA is one of them. I tell people all the time, to say, well, how do you believe in the FDA? And I said, well, if you don't, then you really shouldn't eat anything that comes from the grocery store. Do you know that's all approved by the FDA too? Yeah. You shouldn't take aspirin. You shouldn't take Tylenol. You shouldn't eat foods. It's all approved by the systems that we have come to know and trust. And this vaccine is no different than that. But I think it's going to be a lot of education, again, from the trusted sources that families know, to really spread that level of understanding and comfort. And I hope with that will come a lot of individuals getting the vaccine, because I think that's really important. And I think also, every death is a terrible, terrible death. But I think in particular deaths of children, and we're sensitive to it, right? We're pediatricians, is so devastating. So if we can avoid one death, that's a success in my mind, right? That's why we are such proponents of vaccines, because if it can prevent one death, one child, one family, that agony of having to go through something like that, it outweighs everything in my mind. So
yeah, I think from a public health perspective, as communities are thinking about whether to require vaccination for children, I think you can make a case, and one of I think the strongest reasons to make the case is that with ongoing transmission, we continue to have more and more variants, mutations springing up. And children are part of that transmission. Again, it may be lower than with something like the flu, but they are part of the transmission. They do bring it home to family members who may be at higher risk. But even if they're not, the transmission from child to child can allow variants to spring up. And we've been lucky so far that the variants have been covered by this vaccine, but it's very possible that you could have a variant that was not. And and so that kind of population level community control, I think, would be a justification. But I'm asked a lot about, well, should the CDC mandate the vaccine for children? It's like, well, that's not how the system works. Each state gets to decide which vaccines are required for school entry. It's not something that the CDC has the authority to do. And I I mean, you see such a red-blue divide in this country in terms of following public health guidance. I think we could very easily end up with a patchwork where there's some states where it's required and some states where it's not.
Yeah.
And that would not be a good thing in my mind.
It really wouldn't. And, and that delves right into this question of herd immunity. So if a state mandates it and everybody gets it, then hopefully we get to this herd immunity sooner rather than later. If you have a state that doesn't, you could end up just with that. Even within that state, you will probably have pockets where there have been higher rates of COVID. And there will be some communities where the whole community gets the vaccine. And we've already seen that, right? So if you look in New Jersey at Hunterdon County, there's just a vast majority of individuals that have received the vaccine already. And then you look at a city like Trenton and only 17% of that, 17% of the African-American community have received the vaccine. Mm-hmm. So you've already got these, geographical differences. And that would be really unfortunate because it will just, again, foster everything we've just talked about in terms of inequities and the consequences of high COVID infectivity rate within a community.
I've stopped talking about herd immunity because I just see so much confusion around it, because the point you're making, that this concept of herd immunity, where if enough people are vaccinated, you're not going to see spread within the community. For that to occur, you have to have those rates in every community.
That's right.
And we know that that's just not the case in some communities because there hasn't been access. And the early maps of vaccination were shocking in that they were like mirror images. Those communities that had the highest rates of disease had the fewest vaccine sites available and the lowest vaccination rates.
That's right.
But what you're seeing as you go forward and more vaccination opportunities are there, you find this clustering, so that people of similar mind in terms of vaccination tend to live in proximity. So very conservative communities may end up with vaccination rates that are quite low, and that allows disease to spread. I prefer, rather than talking about herd immunity, saying, everyone who gets vaccinated is playing a part in decreasing transmission.
That's right.
And so it to me, it takes away this idea of, well, we're not going to get to 70%. Why should I even bother? It's like, no, if you get vaccinated, you're doing your part, because if you run into that virus, it's not going to find a friendly home. It's much more attainable, because I'm asked all the time. It's like, well, we're at 50%, we're at 60% of this community. It's like, no, you're not really, because if you look by age, people under 30, it's at 30%. Young people aren't. So it's going to be very hard to get there.
Yeah, it is. And, also I say, when you're talking about getting there, and as you're saying, reducing the rate, what's really important in that conversation, if I get the vaccine, I'm doing my part. And I try to think about it. And when I talk with individuals, you are helping to reduce the death of someone else. And so that the more and more of us that get the vaccine, as you're saying, the lower and lower the chances of spread. And the reason that is important is because the more spread leads to more infection, leads to more death. And that's ultimately what we're trying to avoid. And, we haven't even gotten to that whole conversation of, the post-intensive care syndrome, right? Post-intensive care syndrome, which we're seeing throughout the country now. Those individuals that have been in the intensive care unit, they are actually having a syndrome where they're not fully recovering, right? They're having long-term lung issues, long-term cardiovascular issues, long-term cognitive issues. So that's a whole nother dilemma for those communities that have been hit really hard.
Yeah, I think that we don't fully understand yet the spectrum of what it means. And we know from some other infectious diseases that certain infectious diseases, if you get them when you're young, can set you up for other health issues as you get older. So there are a lot of reasons to try and knock this down.
That's right. And speaking about this, we often get into conversations. I know I do with my friends and family about what the new normal is going to look like,
Yeah.
Yeah, so I know even in my institutions, in my institution, we're thinking about that. We've worked, particularly the administrative staff, we've worked, the last year, like everybody else, from home. Even our clinical staff, as you know, we've been doing remote for almost 50% of the services we provide now are remote still. And then 50% is face-to-face for those things that need to be done, face-to-face. But you've got a young child with ringworm. You can look at that on the scalp. You can see clearly the rash and you prescribe what's needed. So there are a lot of things that can be done through telehealth, telemedicine. So it's going to be really interesting post-pandemic, again, whatever that means, post-pandemic, how we think about our workplaces and education as we go forward.
Yeah, you and I had a conversation once before on Facebook, and one of the things that really struck me was you talked about access to mental health services.
That's right.
What is it that you've seen during this pandemic in terms of mental health services and your ability to provide those services?
So interesting. So we've actually seen an increase in being able to provide those services. And I think a lot of institutions have. And so you have to be wary of that too, because it's a little bit of you have to be wary and cautious, because there are some people that may not have the technology. So that issue of digital divide is still there. Another thing that we have to address as, we are moving through this pandemic. But for a lot of individuals, they have access to a smartphone. I would say 90% of our patient population has access to a smartphone. And so we've really seen an uptick in the number of families and individuals we've been able to serve and provide mental and behavioral health services to because of the technology. We've had individuals and patients that we haven't seen for years. And then all of a sudden we'll see them, one of our behavioral health providers will be like, we've been looking for you for the last X amount of months. And they're like, well, now I can just call you up on my phone and have access. So that's really remarkable. That's one of the sort of the silver linings to this tragedy, if anything, that we've now tapped into a resource that has allowed greater access for a whole swath of individuals.
I just think from an equity perspective, that's critical. And when you talk about equity, you're talking about opportunity. And the number of times I've used the phrase in the clinical setting, well, this patient is non-compliant. They're not following the advice. Rather than thinking about, well, what barriers are there for this individual in terms of that? Well, whether it's transportation or time off work to be able to come in to be seen, or childcare or something else, just to see that when you're able to provide a service so easily through telehealth, the number of people who are like, thank you. I finally can access these services that I've wanted to access, but just was unable to do so.
Yeah, that is so interesting, right? So our productivity, because we went to telehealth really quickly when the pandemic began, sort of this time last year. We converted all of our services within the span of 1 week. So, because right when the pandemic happened and everything was new, and the governor first put out his executive order for stay at home, we converted all of our services to telehealth within that week. And we shut all of our sites down. So we were 100% telehealth for like the first month or two. And it was just, as you said, really dramatic to see that not only did our productivity not go down, it actually increased. And just the amount and number of individuals that were accessing us really demonstrated that point, that when you reduce those barriers, it's not about being non-compliant, which is a dirty word for me. I hate that word.
I know, right? Yeah, it should be just
removed
from
just removed
from the vocabulary.
But when you really reduce barriers, then all of a sudden, not all of a sudden, but then you really see people that access the system. You know, as a pediatrician, I often used to think, I used to think, what am I not doing right? And maybe that was just me when I would have a family come through, and I don't know what they were asthmatic, for example, and they were wheezing. And I said, well, take this medication, here's the machine to take your medication. And I want you to see a lung specialist. And then they'd come back and maybe they didn't do everything I'd asked. And I would always scratch my head, like, what am I missing? Because I know they wanted the care, otherwise they would not have come in. But what am I missing? And again, as you learn more about adverse trauma, toxic environments, the inequalities in our system and barriers, right? Then you learn, as you're saying, Rich, to ask a different question in terms of, what do I need to provide to help this person get over their barriers? What is their barrier, number one? And how do I help them overcome that? Which is a really different way to think about that. And I think we're going to have to think a lot about that post-COVID, right? How do I help individuals overcome these barriers?
As a foundation, we're focused on how do we change the conditions so that there aren't so many barriers. That's right. In the first place. And it comes back to that equity issue. I think for this audience, an important context. Right now I'm in Princeton, New Jersey, which is where our foundation's located. It's also the town I grew up in. A child born here in Princeton has a life expectancy at birth of 87 years. I volunteer at your clinic in Trenton. It's 14 miles down the road. And a child born near that clinic has a life expectancy at birth of 73 years. So 14 miles and a 14-year difference in life expectancy. So that has nothing to do with anything apart from where they're born.
That's right.
And so it begs the question, what do we need to change as a society so that your life expectancy isn't so determined by where you happen to be born and grow up? And so that you're not seeing as many asthmatic children. You're not seeing as many children who are exposed to environmental racism, worse quality air, living near more industrial settings. The air here in Princeton is pretty good. Well, the air, if you live next to a manufacturing plant, may not be. And so shifting this focus, just as we were talking about COVID vaccination and the systems that make it hard or make it easy, how do we change the structures and systems so that your opportunity for health is not dependent on your income or the color of your skin?
That's right. And so, this conversation is so interesting because, as you're saying, the answers to creating equitable systems of recovery, whether that's health or education or the justice system, really relies in this changing the structure. And so when we talk about, structural racism, we're talking about systems and institutions that have been built over decades that disenfranchise a group of individuals. And then you've created, and then what that system has done is created these pockets of immense poverty, of lack of education, of lack of resources. And then in those pockets, now you get all of the consequences that we see: poor health outcomes, lower education, et cetera, et cetera. And so really what you're talking about is, how do you change that equation, change those structures, change those systems to uplift an entire community? It's a big task, but
COVID just makes it so clear.
Exactly.
Early on, when data were first coming out as to higher rates of COVID and severe disease among people of color, the comment was, well, people need to change their behavior and wear more masks and so on and so forth. What's been clear is that it's primarily due to exposure risk and the disproportionate percentage of people of color who are in lower paying jobs or essential workers, and the lack of attention to protection of people who are in lower paying jobs. But it begs the question, what is it about our systems and structures that leads to less opportunity for people of color?
Right.
and a greater proportion in lower paying jobs. And it comes then back to the systems,
right.
how we fund education in our country. Why a student in Princeton, New Jersey is getting a very different educational experience than one in Trenton, New Jersey.
That's right.
And do we care about that? And
Right.
can we see the connection to health?
Right. I think that's the interesting question. Do we care about that? And I think, again, COVID has shown and sort of had this spotlight on this, because if you don't care, it does affect all of us, right? So just as you said, if you've got pockets of communities that have COVID and they don't get it under control, you don't provide the resources to help that community, then it's going to spread back to your community, and it's that way with everything, right? And so that it's not just them, it's really is us. And there is a consequence to having, locales and pockets of municipalities where there are just groups and swaths of individuals that are disenfranchised, because it does have an impact on all of us.
Yeah. The toll of this pandemic, we've talked a lot about the health toll. The economic toll
right.
has been again disproportionately felt by communities of color, by women. For this audience, clearly the toll on women in the workforce has been enormous, given role as primary child care givers and caregivers for elderly relatives. The loss of the caregiving system that so many relied on has forced so many women out of the workforce at much higher rates than men. And that has health consequences, but it also has consequences to the vitality of communities. The fastest growing sector was women entrepreneurs, and women entrepreneurs of color, and that's been hit the hardest.
That's right.
I mean, so important that with the recovery that the dollars are intentionally put to address those issues.
Yeah. So as we think about that, whether it's the economics, it's education, it's health, we've got to think about how do we get to the lawmakers, the legislators, the regulators? How do we share the data, share the information to make the case for the changes that we need to see?
Yeah, here in New Jersey, as a foundation, we're a national foundation, but given our history in New Jersey, our special relationship here, we do a lot of work, and we've done work with the Policy Institute at Rutgers on a policy agenda for New Jersey that lays out things that the state could do to address a lot of these issues around equity, that look at housing, look at food insecurity, that look at education, job opportunity, and draw the connection between those factors and health. So often we think about, well, health is a personal choice. You can decide to eat right and exercise and do those things, get a good night's sleep, get vaccinated, and you'll lead a healthy life. What we're trying to do through this policy agenda is say, personal choice is important, but the choices you make depend on the choices that you have.
Exactly.
And if you're not addressing these other factors, you're not going to have impact. And
that's right.
It's shifting from this being so primarily about personal responsibility to saying, what kind of state do we want to live in? What kind of society do we want to live in? Whose lives do we value?
That's right. I mean, it is such, as you said, this idea of the difference between where people live, their circumstances, where they're born, their locale, and the systems that are surrounding that individual from the moment they're born. I always remember this one scenario, and it has stuck with me forever, that there was a young baby I was seeing, and he had a diaper rash, so he had a diaper rash. And it could have just been, he's got a diaper rash, I give him some cream, mom leaves. But I really wanted to know why, because I know the mom really loves her child, and he had a really bad diaper rash. So it wasn't making sense to me. So I asked her why, like, what's happening? And she says, well, she has to work really long shifts and she has to take her baby with her. And he stays in the playpen on the side while she works. And I just remember thinking, as you're saying, how the life of that son is very different than the life of my son, who was around the same age. You know, and so this idea of structures and systems and opportunities has a direct impact on who we become. And we have to really tell that story, share that information to change the systems. Otherwise, we continue to get the same outcomes.
The stories are so important. I've learned so much from my patients and their families over the years. When I worked in New York, I worked in a federally qualified health center there in Harlem, and we provided care for a lot of children who were in foster care. And I remember this grandma who was there with her two grandchildren, and they were in family foster care. And I think they were like 9 and 11. And I was going through my guidance around physical activity, and I said, well, you know, the CDC recommends, 1 hour of physical activity 5 days a week, but we are going through this whole thing. And I said, how much physical activity do your grandchildren get? What do they do after school? And she said, well, they do their homework and then they usually play video games. And I said, well, CDC recommends that they get physical activity. She says, I know what the CDC recommends. She said, it's not safe for them to go outside and play in my neighborhood. And it hit me that so often we say the answer is education and ad campaigns, when so rarely is that the driver in terms of people's decisions.
That's right. Yep. All right. Well, I think we've got some time for a couple of questions.
Yeah, Dr. Ali and Dr. Besser, thank you so much for this inspiring and in-depth conversation. Before we get into the Q&A, I would just like to remind our guests to post their questions and their comments in the chat, because we have a little bit of time here to take questions from our guests today. And while you're there, we would love for you to consider making a donation to the Fund for Women and Girls. Our team will be posting a link, and your contributions today will support our 2021 grant making process. So we would truly appreciate it and be grateful. So I'd like to start with the questions for the doctors. And we started the conversation off around vaccine hesitancy. And we have a few questions in the chat with regard to that. So I'll post the first. We talked a little bit about hesitancy and is the term accurate, and really is it about equity and access? And the questions are a little more specific. Someone asked, what are your thoughts on the J&J vaccine being given to marginalized communities where there's little choice to these communities as opposed to other communities in our community? And with the concerns about safety, do you think that this is contributing to this hesitancy that we're hearing about?
So I feel the Johnson & Johnson vaccine is still very safe. I recommend it to my family, my friends, my loved ones. I got the Moderna, but my husband got Johnson & Johnson. So I think the toll, as we've been describing, the toll on our communities is, particularly communities that have been disenfranchised, communities of color, is so great. And the efficacy really of all three vaccines is so high in terms of reducing hospitalizations and reducing deaths. Those are really two important variables that I recommend everyone get the vaccine that they can. And for that reason, we still offer Johnson & Johnson. Again, I think when you compare the really low and rare risk of the Johnson & Johnson vaccine and the blood clots that have happened with just the immense and enormous toll that it's taken on communities that are disenfranchised, it's the benefits far outweigh the risk.
Yeah, I'll before I say anything on that one, I need to I need everyone to know that our foundation was founded with money from the Johnson family fortune, and we own significant stock in J&J. That being said, I agree with Kemi's comments about the safety and effectiveness. I think there are challenges though, and I think that it is important for people to have choice. One of the hardest things I think to deal with is issues of risk, and we all have different risk perceptions. And to me, 1 in a million may sound small, and to someone else that may sound like, wow, 1 in a million is not bad. I buy lottery tickets and my chances are worse than that. And if our goal is to get people vaccinated, you really want them to be able to make an informed decision. I think it was really smart. It was very important for the government to take a pause on the J&J vaccine when they first had signals of an issue, so that could be investigated and looked at and to determine, well, how big is the risk? And then I agree with their decision to say the risk is really small. We think it should be made available, but Denmark just made a decision that they're not going to use the J&J vaccine. As those kinds of things happen, it will feed into people's decision making. So yesterday when I was hearing our state health commissioner talk, she says that it will be a real challenge to not be able to have a vaccine where you can provide protection with just one dose. In particular, for people who are homebound, where they're coming out and reaching people in the home, it was really great to have a one-dose vaccine. But even in those settings, it's going to be important that people have a choice.
I agree. Yeah, I think that is so important. And that's one of the lessons learned from our history with marginalized communities, that really a lot of what has created the distrust that we've talked about over decades is that lack of choice, that lack of informed decision making. And so, I think it's really important that we have that now. We try to educate, we try to inform, and then you have to allow people to make that choice. Otherwise, we end up doing just what we've done for history's past.
We're in an incredibly privileged position right now, in that we're just a little over a year into this pandemic, and we have 3 vaccines that have been authorized, and we have enough vaccine in America for every adult who wants it. That's another topic in terms of why aren't we doing more to provide vaccine for people around the globe when we've got so much here. But given that there is choice, trusting people to be able to make their own informed decision, I think, is really so important.
We have a follow-up question with regard specifically to the vaccines. One of our guests wanted to know that, that RNA vaccines have been around for many years, but many believe that they've just been discovered in the last 13 months. Would you be able to address a little bit about the research and the development of these vaccines?
Go ahead, Richie.
Yeah, I mean, this is one of the problems. I think was when the pandemic started and they coined the term for vaccine development, warp speed.
Yeah.
I mean, it gives a sense of urgency and commitment to doing something quickly, but it also is a challenge if you want to have a message that no corners were cut in terms of safety. No corners were cut in terms of testing. Is this effective? What was cut was red tape, and right. Yeah, but the term warp speed is like, whoa, that was fast, and it then coming back behind that and saying, well, actually, there were decades of research that were underway that led to the technology of being able to make these messenger RNA vaccines. And it's one of the reasons why it's so important to support basic science research, because it is a slow process. It was just the finish line piece of developing the vaccine for this virus that was done over the course of the past year, not the technology.
And I'm sorry, a question just came in about boosters. And many believe that vaccines are for life, and now we're hearing that we need a booster.
Want to take that one?
Yeah, I was going to say, well, boosters are very common in the vaccine world, as Richard and I both know. I mean, we have to give boosters all the time, so it is not uncommon. And it's, you know, it's not a booster, but it's you get a new flu shot every year, right? And as we're talking about these variants, one of the reasons we may need a booster is because of the variants, right? Because there may be change, there may be seasonal change. We don't know enough yet. But boosters are not uncommon. We do it all the time in with our pediatric population. You know, we should all be getting our tetanus booster for those of us who haven't, right? So it's a very common practice, and this may not be that different.
I think that as pediatricians, we can help bring down a little bit of the temperature around this idea of boosters, you know, because it is so common. And over the course of our careers, you know, there have been new boosters that we've done, because we've learned that over time some protection you need to give a little more oomph to. You know, when I first started in pediatrics, we weren't giving boosters for measles. You got one when you were at 1 year, and that was it. And then over time, there was a recognition that you're going to pick up a certain percentage if you give a second shot before school entry. It's like, oh, so that's a booster, and it wasn't such a big deal. Some of it, I wonder if it's because adults don't like shots so much, and yeah, booster. There may be I also think that it was premature to announce that there will be a booster. It was announced by the head of Pfizer, and it's not been determined. That's something that the advisory committee to the CDC would make a recommendation on. And I think it may have had a little bit more to do with stock price than it had to do with the true you know, decision that there will absolutely need to be boosters.
Yeah.
So the Fund for Women and Girls is about to embark on their 2021 grant making process. And one of the questions that was posed was, what is philanthropy's role in supporting equitable recovery from the pandemic, especially when it comes to health? And what is the best way that we can be supportive?
Yeah, I mean, that's a great question. When I think about the role of philanthropy and what it can do in communities, I think one of the most important thing it can do is listen to people in communities, so that the needs are identified by community, and the approaches to addressing problems are community driven. We put out principles early in the pandemic. We put out principles for an equitable recovery. And one of the key ones was the engagement with community around solving problems. So it's, you know, there are a lot of people who are working in communities to address systemic and structural issues, as well as to address immediate needs. And different philanthropies will come at it in different ways. Some will be providing food and shelter and income support, and others will be working to change laws and regulations that need to be changed if you want to affect the systems at a greater level. And so both are really important.
Yeah,
what do you think?
Yeah, I completely agree. I think as a philanthropic organization, you have to decide how upstream you want to go in your mission, and then in your priorities. So I think, because obviously there's a short-term need, as you mentioned, of food, of resources, of housing, but then really there's a long-term upstream that can affect those things as well later on down the line. So I think an organization has to decide where they want to fall. Maybe it's a combination of both, but I think both are really important.
Thank you. One of the questions really focused on fair and equitable. Both you, Dr. Besser, and Dr. Ali talked about herd immunity, health systems, and a shift from looking at the individual and back to our systems and structure. Yeah. And a couple questions came in about, now that that's fair, front and center, how can we continue this momentum of creating these fair systems? Yeah. What messages and actions can we take now? And are you seeing many of our local health systems begin that work?
I think so. I know we are. So for example, the Trenton Health Team is an organization, it's a nonprofit in Trenton, made up of Henry J. Austin, the hospitals, the Department of Health for the city of Trenton. And we actually are looking at those systems now. How do we take lessons learned and how do we change some of the structures even locally? So I do think that this is an important, question to address in terms of sort of what's needed to make those structural changes. I think how do we keep this momentum going forward really is, I think, something that Richard tapped into is how do we take the experiences, the knowledge from the community, from the individuals impacted, and then set systematic policy change to improve those structures and those systems. And I think that has to be our thought process as we go forward. How are we learning from the communities, learning from the individuals, taking their experiences, and then setting systems and structures to change that over the long term? I think that's where we're really going to see a significant impact, and an impact that can be sustained over a long period of time.
One of the big areas that we work on is policy at the federal level. Mm-hmm. And so we were doing a lot of work around what needed to be in the American rescue plan. And when you look at what came down in terms of supplemental support for SNAP, which is the Supplemental Nutrition Assistance Program, child tax credits, earned income tax credits, money in people's pockets. Research that we funded at the Urban Institute has shown that package will reduce child poverty in America by 50%. 50%. But it's time limited. And so now our focus is, okay, how do you take that and say, do we value that in America? Do we value having less children who are below the poverty line? How do you move that to be permanent legislation so that people have what they need for a healthy and successful life? So we're working at that level, and it's critically important that we see those changes take place if we truly want to improve the lot for everyone in America. These fundamental American values we lift up of opportunity, do we believe in them, or are they just words? If we believe in them, what changes do we need to see?
Yeah. And I guess that we have time for one last question. And someone wanted me to ask doctors, where do you hope we'll be 1 year from now?
Oh boy. Oh. So I hope some of the gains that have been positive are not lost. So as we talked about increased access, we talked about being an understanding that the COVID has shown a spotlight on the disparities and the systems that need to be changed. So I hope from a year from now, we're actively working on those systems and structures to improve the communities that have for so long been disenfranchised. And I hope the access and the systems that have been created now that have improved that access are not dissolved. So I'm hopeful of those two things.
Yeah, I'm hopeful that what was revealed over the past year with the COVID pandemic, the economic crisis, and the movement for racial justice following the murder of George Floyd leads to continued conversation and dialogue and a commitment to changing systems in America, so that everyone has a fair and just opportunity for health and well-being, and that it's not viewed as something that happened and we're past that, but it's viewed as we need to make changes so that the next time there's a pandemic, the burden is not felt so disproportionately by some communities, and so that the periods when we're not in a pandemic aren't a crisis for so many in America.
Yeah.
Well, that is just a great way to end this event tonight. So thank you so much, Dr. Ali, Dr. Besser. It has truly been a pleasure and an honor to host this conversation and have you with us. And we hope that you enjoyed it as much as we did. On behalf of my co-chair, Isabel Zisk, the fund leadership team, and our members, we want to thank everyone for joining us today, for your generosity to the Fund for Women and Girls, and for your continued support. We depend on your donations to help women and girls in our community. If you've not yet given yet, we hope that you'll consider making a gift right now. You can use the links in the chat or simply text WOMEN to 44321. If you've already given, thank you so much, and we hope that this conversation has moved you to want to make an additional gift to support our work this year. If you'd like to learn more about the fund's work, the nonprofits that we support, our grant making, or even how you can get involved, please click on the links in the chat or go to our website at pacf.org/FWG. Collaborative giving is central to our mission, and we truly believe that we can all do better when we do it together. So we consider this an honor and a pleasure. On behalf of Isabel and the leadership team, we thank you, and we want to wish everybody a happy Mother's Day.
That's right.
Thanks so much.
Everyone.
Thank you.
Bye-bye.
Bye.